Okay, hi. So yeah, my name is Helen. I'm currently ST3 OBGYN in Wigan Hospital. So this session is just about early pregnancy and the kind of things that you might encounter. I understand that most people are kind of SHO-ish level. So there is a chance you might be either an OBGYN SHO at some point for your foundation rotations, or if you do GP training, then also you come to OBGYN quite a lot of the time as well. Or you might be in A&E or in GP, where you will see women who are pregnant in their early pregnancy, and these are some of the kind of things you might come across. So hopefully it's helpful, just sort of a bit of a run through of the kind of common things you might see in early pregnancy. So I'm just going to start with like basic principles of seeing a patient in the early pregnancy. I know in med school we get taught a lot of different things that that we need to ask pregnant women, and it's quite complicated. But really, it does boil just down to a few questions that are the key questions. So that's what I'm going to cover here. So, well, it's stable is whether they're in A&E or in GP, basically. So the first thing with any patient, of course, is like, are they stable? With a pregnant person in particular, an early pregnancy. Oh, someone's saying the slideshow isn't working. Is that correct? I don't know. Yeah, so if you're seeing someone in the early pregnancy.
I think, sorry, Helen, I think if you just come out of PowerPoint and go back on the slideshow again, just see if it's, yeah, now, do you want to just open up the whole PowerPoint slideshow then?
Like open it from here, or is it working now?
It's move on to basic principles if that's where you are now.
Yeah, is that, and then did something just come on then when I pressed, or no?
I think because it's not on a slideshow, it's on just like a, like on PowerPoint. You know what I mean?
Oh,
you just need to click your. We can see we are on your PowerPoint screen, but not on a slideshow.
Yeah. How do I do that?
I've got someone saying if you press the third button, it will present it. Is that better? Just press F5.
Okay,
Helping us.
can do that.
Thank you.
Welcome to VoiceOver. The VoiceOver quick
that.
start. Practice
Oh
what you learn.
Sorry, everybody. I'm totally.
Application. PowerPoint. Early VoiceOver off.
Oh my gosh, I'm one of those people I always used to think was so stupid they can't use PowerPoint or anything.
Welcome to VoiceOver.
No,
VoiceOver speaks description.
Not working. Okay, shall I just do it with I'll just do it like this, I guess. Yeah, let's just move those so you don't get a preview of all those things. Okay, well, I'll just do it on here. Fine. So the basic principles of seeing a woman in the early pregnancy. Basically, anyone you're seeing in A&E, of course, you're always going to check she's stable. With pregnancy in particular, you're always going to check the first thing you want to know with early pregnancy is when their last menstrual period was, just so you can know roughly how many weeks she is. So it doesn't have to be like exact or anything, but just sort of roughly how many weeks does she think she is pregnant, basically. Another important question for a woman who's in their early pregnancy is if she's had a scan yet this pregnancy. Of course, if she's had a scan, then much more likely to know exactly how pregnant she is, more reliable than the LMP. And of course, that also tells us the most important thing in early pregnancy is the pregnancy in the uterus, or is it not? So that's kind of the main thing that we are worried about in the early pregnancy, essentially. Of course, with any history, you're going to just ask generally the symptoms, what she's come with. examination for someone in the early pregnancy is abdo exam. And depending on where you are, if you're an A&E SHO, you're probably not going to do the speculum and bimanual. But if you're an OBGYN SHO, then you will definitely be doing a speculum and bimanual. And then just thinking about what further investigations we need to do, or if you're an A&E or GP, whether you need to refer the patient to OBGYN. Yeah, well, there's going to depend. The swabs is going to depend on exactly how they've presented to you, basically. So that's kind of in the further investigations part. So further investigation or things that you need to think about in early pregnancy. So there's the usual things you always have to think about, of course. You know, if you're seeing someone in A&E, do they need bloods? Do they need a cannula? With a pregnant woman, very important always to do a pregnancy test, always. She may tell you she's pregnant. She may not be pregnant. She may not think she's pregnant, but she is pregnant. It's very important to do a pregnancy test in anyone who is, you know, whatever, 12 to 50. Very important. And then, yes, has she had a scan? And then this is going to depend on what kind of further management you might take from that point onwards. So if she has had a scan before, you know, depending on why she's come to you, she might need another scan. If she's never had a scan, the most important thing is to do a serum HCG, because then this is where we get our starting point about how many weeks this lady might be. However, if she has already had a scan that has shown a live intrauterine pregnancy, do not repeat the HCG at this point. HCG levels start to drop after about 9 weeks. So if we're doing repeated HCGs in someone who's over 9 weeks, we may see the HCG dropping, but that actually doesn't mean there's anything wrong with the pregnancy. That's just the natural curve of HCG at that stage. So HCG is really only useful for very early pregnancy. But when someone comes to A&E or GP or to our unit, and we don't know how many weeks she is, we need to start with HCG. Okay, so I'm going to kind of work through cases. I think that makes it a bit clearer of exactly what we would do in real situations. All the cases from this presentation are real cases that I've seen over the years. So hopefully they do make some sense. Fine. Let's see. So first case. So the 24-year-old female goes to A&E. She tells you she is about 6 weeks pregnant and she's come with lower abdominal pain and PV bleeding. So what are we thinking could be going on with this lady, and what further questions might you need to ask her to get a bit more of that history, really? Just I'm watching the chat box. Yeah, ectopic is always, yeah, well, that's the thing we're all the most worried about. But yeah, ectopic, but also getting miscarriage. Yeah, these are probably the main two things that we're going to be considering. Yeah, I mean, she could have infection as well. That's true. Yeah, ectopic. Good. So they're the main things we're going to do. But obviously, we're going to need to. Yeah, abdo pain, you could have a UTI, that's true as well. Don't normally give you bleeding as well, but that could just be incidentally at the same time. It's always important to think about other reasons why pregnant women might have abdominal pain. That's very good. It does happen sometimes with low abdo pain. Might not be an ectopic, maybe it's appendicitis. You know, things can happen at the same time. So basically, we need to get a bit more history, don't we? Because like lower abdo pain and PV bleeding is a bit vague, really. So this worked better when it was a slideshow, but anyway, you've got all the answers straight away. So first thing we need to ascertain, is she definitely pregnant? So we definitely need to do a urine pregnancy test. As I said, it sounds very callous or harsh or something, but essentially you cannot trust anybody about their pregnancy status. Very important to do a urine pregnancy test. Whatever they tell you, do it anyway. If she can tell you her exact last menstrual period, brilliant. Then you can get an idea about how many weeks she is. Has she had a scan yet this pregnancy? Always, I'm obsessed with that. Generally, you know, she's got pain, so you're going to do a Socrates. You're going to try and quantify the bleeding. So is it heavy? When did it start? Is it fresh red? Are there clots? Have they seen any products of conception? They may not have any idea about that. But, you know, sometimes they will come and tell you they think that that's what they've seen. And then any associated symptoms, so things like dizziness, collapse, vomiting, shoulder tip pain, things like this. And then, of course, you're going to do an abdominal examination. And then if you're an OBGYN, you're going to do speculum or bimanual. But if you're just an A&E, you're probably just going to stop at abdominal examination. So for this lady, so she did have a positive pregnancy test. That was good. Yeah, any foul smell? Yeah, maybe, but there's unlikely to be infected at this earlier stage. But you know, you can ask them that question as well. Urine, yeah, she had blood. And a urine dip only showed blood, so no specific signs of a UTI. Her last menstrual period was 6 weeks ago. She has not had a scan yet. She's had the lower abdominal pain for about a week, gradually getting worse. It's moderately painful, suprapubic and crampy. Bleeding again also for about a day. Fresh red, getting heavier now, very heavy, changing pads, flooding. So a good way to try and quantify bleeding is to ask how many times they are changing their pads. But also when they change the pad, is it full? Flooding is another good question as well, because that signifies definitely heavy bleeding. Some women will change the pad very frequently, even if there's not much on it. So just the fact they're changing pads may not mean anything. But if someone bleeds so heavily that they flood through the pad, then that is a lot of blood. She's mildly dizzy on standing, but otherwise she's okay. Abdomen's soft, she's a bit tender, but no guarding. You can see, doing your overall inspection, that there is some blood staining on the trousers. So that kind of makes you suspect that, yeah, okay, she is bleeding pretty heavily, actually. Blood pressure is on the lower side, but, you know, depending on the person, that might be within normal range. Again, heart rate's a little on the higher side, but not too bad. Other obs are okay. So you're the A&E SHO. So what are you going to do now? Any suggestions in the chat box? Yeah, definitely IV access, bloods, group and save. I'm glad everyone's saying group and save. That's very good. That often gets missed in A&E, so group and save is very important. Obviously, she's bleeding, so, you know, she might need to have some blood potentially. And just, yeah, IV access is good because it does sound like a fairly heavy bleed, and the blood pressure is on the lower side, so I agree about that. We don't generally give TXA in the context of a miscarriage, not usually, but you could do it. It wouldn't do any harm. And certainly when women come to us via ambulance, they have often had TXA in the ambulance. So that's no harm to give that. Fine. So what happened? So yeah, she had bloods. Obviously HCG, very important. FVC, uni, and group and save. Cannula. You know, she's bleeding quite heavily, so really, I would think she needs to have at least a green, personally. But you know, whatever you can get in really is okay. But ideally a green or above, depending on how heavy she is. Yeah, someone said stop blood thinners. Yes, but it's very unlikely that a 24-year-old who is fit and well is on a blood thinner. But if she is on a blood thinner, then yes, to stop that. Obviously, to stop that, yeah. So she's fairly stable. So she got referred to gynae. So she was just in A&E waiting to be taken up to the gynae assessment unit where I was working. So, however, she then suddenly says, I really don't feel very well. Pain is suddenly much worse, and you can see suddenly a big gush of blood. When our obs are rechecked, she's now bit more hypotensive. Heart rate's well, it's not too high. It's okay. And she's just otherwise she's okay. So now, what do we think? Do we think this lady should continue her journey to the gynecology unit, or should she stay in A&E, or what are we going to do? Yeah, potentially could need to have some blood. Yeah, that's good to think of, definitely. Yeah, definitely stay in A&E. Obviously, that's what I'm trying to get out with this one. But yeah, potentially move to resource. That's a good idea as well. Monitor observations. Yeah. Depending on for the major hemorrhage protocol, someone said, depending on your hospital, she's probably not there yet. Because generally it has to be a certain volume of blood loss before you can activate that. But certainly, getting access to some blood or potentially getting the O negative blood could be a good idea. Someone said prep for theatre. Yes, probably a good idea to, keep an OML, things like that. So what did happen? Yeah, get the gynae read. Yeah, get gynae, I think, is important at this point. If you're working in A&E and you're comfortable to do a speculum, then brilliant, you can do that. But essentially what this lady needs is a speculum. That's the key thing. Speculum and probably some fluid at least, and maybe blood. So yeah. So she had some fluids. Gynae came straight away. We did a speculum. The products was in the cervix, come out and when you just remove them with sponge forceps. Then following that, her pain and bleeding stopped almost immediately. And following that, our observations were okay. When the bloods came back, obviously this was like a bit of delay by the time, she was quite well by the time bloods came back, but HB was okay. HCG moderately raised, about consistent with 6 weeks. Everything else was fine. And then basically she was fine after that. So the main point of this case was that sometimes if there's something stuck in the cervix, that can make them suddenly drop their blood pressure and they suddenly have increased pain and bleeding. That is a sign that there is something stuck in the cervix and that what we need to do is look at it and get it out, basically. Essentially, when your cervix, for some people, not for everybody, but for some people, when the cervix gets a bit distended, they have a vasovagal, essentially, or a vagal response. So blood pressure drops, and also the heart rate drops a bit lower. Not low, but you could see, you would think with sepsis or something like that. When the blood pressure is low, the heart rate is high. But when you get a vagal response, you get the normal heart rate still with a low blood pressure. Yeah, and this lady essentially, this is a good sort of case of how resilient young people are, because she lost all that blood, but she just went home later on that day. She was fine. So where am I at now? So the key points from this essentially is if you see an acute increase in pain or bleeding, that can signify that they're actively passing the products, and basically you need to do a speculum. Management. So if in this case, if we'd done a speculum and there hadn't been anything visible, then yes, theatre would have been the next step for her. But because we could remove products, we could kind of do that there and then. That makes sense to do that. But if there's nothing there to remove, then the next stage would be to go to theatre to remove. Yeah, so management is essentially just supportive care and stop bleeding. It's fairly straightforward like that. So generally, you know why she's bleeding, well, you suspect why she's bleeding. It's from a miscarriage or from pregnancy of some kind. So you need to stop the bleeding, basically. And yeah, bleeding can be very rapid and they can lose quite a lot of blood, even though they are very resilient. They can only be resilient for so long. So yeah, you need to consider theatre and blood transfusion early, which a lot of people said, which was really good. Someone asked, would she still get a scan to exclude any retained products? Essentially, we would look at the products that were removed. And if it looked like the majority, probably wouldn't do a scan, to be honest. If she ended up staying in the hospital because she was unwell, then yes, we would do a scan. If she was well enough to go home, we'd probably just let her go home and then ask her to do a pregnancy test in 3 weeks, and it should be negative. If it wasn't negative, then we'd do a scan at that point for retained products. And yeah, someone said next step would be D&C, yeah, if we still weren't able to control the bleeding. So that's that case. This lady had a miscarriage. So I'm just going to briefly go through miscarriage classifying and things like that. I used to get confused with it in med school. Although, to be honest, it doesn't really matter that much in real life. So miscarriage. So a miscarriage is a loss of a pregnancy before 24 weeks. So, you know, the majority of them are early, obviously, but they can happen. It's still classified technically as a miscarriage, even if they are 23 and 6 weeks pregnant. So they're very common. Probably about a fifth of pregnancies end in a miscarriage. It may be even higher than that, as if you have a very early miscarriage, you know, at 4 or 5 weeks, you may not have even realized that. A lot of women may not have realized they were pregnant and just thought that they had a heavy period that month. And yes, the majority of miscarriages happen before 12 weeks. If you have bleeding after 24 weeks, it doesn't count as a miscarriage. It would be an antepartum hemorrhage at that point. Just NB. So causes, I mean, most of the time we have no idea really why a certain particular woman has had a cause, a miscarriage, but it's very important whenever you ever see these women, very important to be clear that there's nothing that the patient has done to have their miscarriage, and there's nothing they could have done to prevent it either. The women ask this very, very commonly, and it causes an incredible amount of distress if they are ever told that they have caused it. Women remember this for the rest of their lives, so it's very important not to say that to them. We don't really know most of the time, but the most likely thing for most women is that there would have been something wrong with that pregnancy, either that basically meant that it was not going to be able to be a viable baby at the end of the pregnancy, and when that happens, the body will miscarry rather than continue on. Some women can have certain things like antiphospholipid syndrome or thrombophilias that cause them to be more likely to have miscarriages. And it's very rare for an infection to cause a miscarriage, really, to be honest. They'd have to be very sick. We did have I have seen one who was 18 weeks who did miscarry, but she had a bowel perforation and all sorts. So this was like a serious infection, not just like the thrush or chlamydia or something. It's a serious septic infection, potentially, yes. Or later on, incompetent cervix. So say, for example, if they had lots of treatment to the cervix from the smear program, something like that, sometimes the cervix can be a bit more likely to open. Risk factors are all the usual risk factors for everything. So being older, smoking, drinking, drug use, uncontrolled diabetes. There is a link as well with low pre-pregnancy BMI, slightly more likely to have a miscarriage as well. The connective tissue disorders is mostly because they're more likely to have antiphospholipid syndrome. So then that is more likely to cause a miscarriage as well. Fine. Someone asked in the chat, sorry, just before we move on, what is the death of a baby after 24 weeks? So that would be just a stillbirth or an intrauterine death, depending on exactly how you want to word it, basically. Right. So classifying miscarriage in practice is not really that important, but just to kind of try and make it a bit clear. So a threatened miscarriage is if they're pregnant, they have bleeding, but when you examine them, the cervix is closed, and on the ultrasound, the baby's okay. So that's a threatened miscarriage. Oh, I'm not going to be able to do this because of the, I'm just going to have to move these out of the way. An inevitable miscarriage with bleeding, but when you examine them, the cervix is open. But if you were to do a scan, you would see that there was a pregnancy. Unfortunately, it's going to be over soon. A missed miscarriage is, they might not have any symptoms potentially, actually. Sometimes women, unfortunately, do go to their 12-week scan and there's no heartbeat, but there's not been any bleeding or anything like that. If you were to examine these women, they would have a closed cervix, and the scan would basically just show a baby that is big enough where we should be able to see a heartbeat, but there is no heartbeat. So I'm trying to get my boxes out of the way now. A complete miscarriage, if the pain and bleeding have settled or improved, cervix will be closed at this point, and if you did a scan, there'd be nothing there. And an incomplete miscarriage is bleeding and pain, cervix could be open or closed, and if you did an ultrasound, there would still be some pregnancy tissue there, but not all of it's passed just yet. Yes, and sorry, so bleeding after 24 weeks is an antepartum hemorrhage, not a miscarriage. I don't know if I'm going to move on. Right. So how do we manage miscarriage? So this is a bit more, when you're actually on the gynae, I'm not going to do this in A&E or anything, but if you're on a gynae place, obs and gynae rotation. So basically, like everything, like most things anyway, management is conservative, medical, or surgical. So expectant management is essentially just waiting to see if the miscarriage happens spontaneously. Women will often choose this course, actually, especially if they're already bleeding. They may just want to wait and see what happens, which is fine. You just have to make sure they understand what's going to happen so that they will have bleeding and pain. Essentially, once the miscarriage is complete, this will settle. They should expect resolution of bleeding by 3 weeks, and they need to repeat a pregnancy test in 3 weeks' time, and it should be negative. And that signals that the miscarriage is complete. With anyone who's having an expectant management at home, any deviation from the above, then the patient basically just needs to call their local unit for advice. So pros and cons of this. Women quite often like it because they feel like it's natural. They say a lot, it's a natural, just let things happen naturally. And they're not getting messed around with too much, which is another pro. It does work eventually. Most pregnancies will pass, even though missed miscarriages. Eventually, they will bleed, and they will pass the pregnancy. Of course, you don't have any of the side effects of medication or surgery, which is a good thing. The cons of expectant management, however, is that it can take a very long time. It's unpredictable. You don't know when you're going to start bleeding. You don't know when you're going to stop bleeding. It can be bleeding for 3 weeks, can be quite heavy for weeks even, potentially. You're slightly more likely to have an emergency admission for heavy bleeding than if you had medical or surgical. Some patients can find the process of having miscarriage very distressing, of course. This is a con compared to the surgical way of dealing with a miscarriage, basically. So some women don't want to bleed, they don't want to see anything. And sometimes expectant management will not work, and they have to have surgical or medical in the end anyway. If it goes on for a very, very long time as well, they can get infection as well sometimes. The medical management of miscarriage is essentially a medication that we can give either vaginally or orally to help accelerate the miscarriage. So it's usually misoprostol. It can be done as outpatient or inpatient. Everywhere you go is going to be slightly different. Most of the time it's outpatient. If, however, they're over about 9 or 10 weeks, generally we would do as inpatient because they could bleed quite heavily at that point. So it's better for them to be in. But if it's in the early pregnancy, they can have as outpatient. Essentially, it's very much like expectant management. Just the idea is you have the medication, it brings on the miscarriage like within the next couple of days, rather than waiting to see waiting however long it takes for the body to decide to have a miscarriage. Again, once they think they've passed the pregnancy, we just advise them to repeat a pregnancy test 3 weeks afterwards. They don't necessarily need a scan or anything like that. Again, some units will vary in that, what they do with that. So pros versus cons. Pro, you avoid an operation and an anesthetic. It's more controlled than expectant. Basically, you kind of know it's going to happen in the next couple of days rather than potentially in the next 3 weeks or whatever. And it is very successful. Around 80 to 90% will miscarry with this with the misoprostol. Cons, so you get some side effects of misoprostol, especially if you take it orally. It just makes you feel a bit sick, really. And you can have diarrhea as well. It can be a bit more painful as the process is a bit more accelerated. Again, some patients find the process distressing of seeing the blood and seeing the pregnancy tissue. And again, it does not always work, and so you may end up having surgical management anyway. The surgical management is often called like D&C or surgical evacuation, something like that, depending who you hear it from. A lot of patients will call it D&C. It's not really what we call it anymore, but a lot of patients will call it that. So there's two different ways. Essentially, they're very similar, but you basically, you can either do it under local anesthetic or in theatre under general anesthetic. They're very similar in how they work, really. Essentially, you're just putting a tube inside the uterus with a suction of some kind to remove the pregnancy tissue. If a patient is unstable or very heavily bleeding, then surgical management is the way to go, because you just get it done there and then, basically. Yeah. So Prose is usually quite convenient for the patient. Like, they kind of know what day they're going to go, and that's going to be the day they have their miscarriage, if you like, or their management. So they can, work around that. It's usually a day case procedure, or often only just a morning or afternoon procedure, really. And generally, they don't have a lot of pain or bleeding afterwards. So it's kind of like a one day and it's done sort of thing. Which is very convenient, if women already have children already. It can be inconvenient to bleed and be unwell for a week. Not everyone can do that. Whereas, this can be done in a day. Some patients prefer not to be aware. As I said, some patients just really don't want to see anything. They don't want to bleed. They don't want any of that. And they prefer just to get it done without having to really think about it too hard. Cons, of course, is anesthetic risk. And obviously these days, it's like difficult to get, it's getting a bit better now. COVID's gone a bit better, but, for a while it was almost impossible to do surgical management for patient choice anyway. And then the surgical risk of the procedure, there is a very small risk of perforation of the uterus. It's about 1 in 1,000 risk chance. And of course, we're introducing something into the uterus, so there's a potential of infection. And of course, you can have bleeding at the time of the surgery as well. Just looking at the chat. Yeah, I don't think there's really much evidence whether it's better to do just misoprostol or to do misoprostol and mifepristone together as a combination. When if we unfortunately have someone who does have a stillbirth later in the pregnancy, when they're more like 30 weeks, something like that, we use the mifepristone and misoprostol. But in the early pregnancy, there's not much evidence what's better, whether to use both or whether to just use misoprostol. Most units just use misoprostol that I've worked at anyway. It's cheaper probably, I don't know. Right, case 2. I'm sorry, I'm running a bit behind as well, sorry. So we'll go a bit quicker through this one. So we've got a 28-year-old female. So she comes to A&E with left iliac fossa pain, and she vomited once, no bleeding. She tells you she's definitely not pregnant. No way can I be pregnant. So, the differentials are the same as what we said before, really, aren't they? And what we're going to do next is the same as well, really, isn't it? We're just going to do our nice history that we've talked about, and we're going to do a urine pregnancy test. So she was seen by a doctor in A. This was, again, a real patient that was referred to me. So that's why it's very specific. Sorry about that. So she was seen by an A&E doctor, and then I got a call as the gynae reg referring this patient to me. So I was told this patient, she's 28, she's normally fit and well, left iliac fossa pain, gradual onset, but acutely worse the last few hours, gripping and in waves, no bleeding or discharge. bowels opened and pressing urine normally. Vomited once with pain, but otherwise systemically well. Observations are normal. Abdomen soft, tender in the lower abdomen with guarding in left ileal fossa. Bloods are essentially normal, and it was referred as a query ovarian torsion, which is kind of fair. If the pregnancy test is negative, that's fair enough. Especially vomiting with pain, gripping, these things are quite commonly an ovarian torsion. And I asked the doctor specifically if the patient was pregnant, and they said no. So I accepted the patient up to our unit. She comes up. The SHO covering the unit says, oh, she's not had a pregnancy test done, actually. So she does one, and it's positive. It's Calciprease. So we added on the serum HCG. The history was the same, basically, as in A&E, and the examination was the same as well. On the speculum, it was unremarkable. There was no bleeding. By manual, she was tender in the left adnexa. However, when she was then getting off the bed after being examined, she had a pre-syncopal episode, and then we had to lie it down. When blood pressure was checked, she had blood pressure was a bit low, heart rate was a bit high. Gave her IV fluids and kept her ill by mouth. This was on a Saturday night, obviously, of course. So she was there. It just so happened there was a nurse sonographer on the unit at the time, so she scanned the lady, and there was a left-sided ectopic pregnancy and a lot of free fluid in the pelvis. When the HCG came back, it was quite raised. Essentially, she was taken to theatre as an emergency, and it was a confirmed ruptured ectopic and a litre of blood suctioned from the abdomen. So basically, my key point is to do a pregnancy test. They can tell you whatever they like about how pregnant they are, but you must always do a pregnancy test. Also, this case was a good case to show how women compensate for a very long time. She probably had most of that litre of blood in her abdomen the whole day, really, but she was fine until right at the very end. And if you do see that there is a sign of compromise, then the patient is very unwell, and you need to act quickly to manage the patient. And with an ectopic pregnancy who's gone to theatre, she will need anti-D if she is rhesus negative. It's always important to remember. It's kind of like everyone forgets it. I forget it as well a lot of the time, but it's very important. So, ectopic pregnancy. So ectopic pregnancy is a pregnancy anywhere outside of where it should be, essentially, which should be in the endometrial lining of the uterus. The vast majority are in the tubes, and the majority are in the ampulla part of the tube, but they can be anywhere, really. I mean, that's the majority of them in the tube. About 1 to 2% of pregnancies is quite high, really, percentage. So you kind of should always be suspecting it, really. And women do still die from ectopic pregnancies, unfortunately, in the UK. So risk factors are things like IVF, all the kinds of fertility treatments, history of STIs, if they have a coil in situ. If they have a coil and they get pregnant, the most likely thing is that the pregnancy will be in the uterus, but they does slightly increase the chance of having ectopic. If they've had a previous ectopic or previous tubal surgery, then of course they're going to be more likely to get another ectopic. Smokers generally as well. However, around a third will have no risk factors at all, so you really can't go on whether they're high risk for an ectopic or not. And this one's going to be ruined by my little box as well. Let me move out of the way. So signs and symptoms. So they can be asymptomatic. That's quite rare, but they can be asymptomatic. Classically, they have low abdo pain that's on one side. However, in reality, it's often very vague and very mild. It can be very vague. Generally, the bleeding is not heavy. That is generally true. They either have no bleeding or they just have like brownish discharge or very light bleeding. If they're a bit worse, they can feel lightheaded or dizzy, shoulder tip pain and collapse. There's often no specific signs. They will be tender, again, on one side classically. And again, classically, they have cervical excitation or adnexal tenderness, but that doesn't happen very often, to be honest. If they're ruptured, then they might have peritonism, and they obviously might be unstable. But the point on my box that I moved was that essentially you can never rule out ectopic pregnancy just from examination. They have to have some investigation. You can't. The only way to know for sure is a scan or a laparoscopy. So you have to investigate anyone. It's like a PE. If it crosses your mind, you have to investigate it. Again, the same with the ectopic. So to investigate, ideally they have an ultrasound pelvis and ideally transvaginal. But if a scan's not available, say it's out of hours, then you do a serum HCG and then repeat it 48 hours later. A rise of more than 63% suggests a viable intrauterine pregnancy. And if it's less than that, then it kind of makes you a bit more suspicious that it might be ectopic. But again, HCG is such an imprecise science. If you have a big ectopic that's sitting right on the edge of a tube that has lots of space to grow, it can grow very quickly, like a normal pregnancy, a big ectopic. And equally, a normal pregnancy that's in the uterus can sometimes have slow growth, or it could be the start of a miscarriage or something like that. So it doesn't mean it's definitely ectopic, but it just means you need to get a scan definitely. Again, if they're very unstable, if there's no facility to scan, then the only thing you can do really is go to theatre and see what's going on. So management of ectopic pregnancies. Again, we've got expectant, medical and surgical. So expectant management of ectopic can be used. They have to meet quite specific, rigid criteria to have expectant management. So you can imagine, obviously, that the risk of rupture is always there. Even very small ectopics can rupture. I've seen an ectopic with a HCG of 70 rupture. So it just, it's not a precise science, but if the HCG is on the lower side and it's falling, then these are good signs that the ectopic is going to spontaneously resolve, essentially. The woman obviously has to be clinically stable. She has to have very minimal symptoms as well. And there are some ultrasound criteria that has to be met. So it has to be unruptured, obviously, fairly small, and not be live ectopic. If you're going to do expectant management of ectopic, they have to have serum HCG every 48 hours initially until we're sure that it's resolving, and then weekly until the HCG is less than 20. So essentially, this requires quite a lot of commitment from the patient, and you kind of need to know they're going to come, because you don't really want these ones to be lost to follow-up, someone with an ectopic pregnancy. So this kind of comes in my pros and cons. So the pros of it, obviously, is it avoids the downsides of having methotrexate and surgery. The cons is it can take quite a long time. Long follow-up, coming for bloods every 2 days is quite a commitment. And it's certainly not appropriate in anyone who cannot speak English or not very well, or if you feel like they're not likely to attend regular follow-up. It's not really appropriate, because we really don't want these women to not attend follow-up and rupture in the community. The medical management of ectopic. So medical management is essentially a single dose of methotrexate IM, which is adjusted for the patient's body mass. About 25% might need a second dose after a week if the bloods are not improving as we would hope. Again, they must meet certain criteria. It's pretty much all the same as for the expectant management, but the HCG just has to be less than 5,000 rather than less than 1,500. Again, they need regular HCG monitoring. So when we give methotrexate, we do bloods on day 4 and day 7, and we expect the HCG to drop between day 4 and day 7. If it doesn't, then that's when we give a second dose of methotrexate. If it does, then they just have weekly HCG monitoring until it's less than 20. Generally, the HCG should halve every 48 hours. So if your HCG is 4,000 something, you can imagine this can take quite a long time to be less than 20. The majority is about a month, but I've seen them go for 3 months sometimes, having to have weekly blood tests. So again, it's quite a lengthy follow-up process. Prose is that it avoids surgery. Obviously, that's good, and it is as effective as a surgical option in terms of the. It is very effective treatment for ectopic pregnancy. Very few fail. Very few need to go to surgery after two doses of methotrexate. The cons, so side effects of methotrexate, again, nausea and vomiting. Methotrexate itself can actually give them some abdominal pain, so that can be a bit confusing because we know they've got an ectopic and then they come with abdominal pain. So it can be challenging sometimes. And if you have methotrexate, we need to check on the LFTs that can affect those. And it's not really appropriate for anyone who has liver disease already. It's a long follow-up again. And if they've had methotrexate, they must use contraception for 3 months after the methotrexate, because of obviously the whole how it works is to destroy the fast dividing cells of the pregnancy. So it's going to be teratogenic for any new pregnancy as well. So again, some people, if they are desperate to get pregnant right now, then the 3 months is too long for them to wait. They don't want to do that. Surgical management is basically salpingectomy generally, ideally laparoscopic. If the other tube is also damaged, or they've already had a tube removed for some other reason, then we can do salpingotomy, which is basically just removing the pregnancy from the tube, but the tube will still be very damaged after that. So that's not really going to be great for their fertility, but we can do that if the other tube is gone for some other reason. But if the other tube looks healthy, then we just remove the tube altogether. And yeah, obviously, if they're unstable, that's the only way to go. You can't give these women methotrexate. You're not going to solve their 1 liter of blood in the abdomen with methotrexate. And also, it can be quite good for people who can't really come for follow-up, or who don't meet. Obviously, if it's too big or the HCG is too high, then they can't have the methotrexate. So Prose is that it's very quickly resolved, obviously, just there and then, pretty much, or within a day. And no follow-up is required, so that's good as well. Cons, obviously, anesthetic risk, surgical risk is any kind of laparoscopic risk, damage to other structures, infection, bleeding. And of course, they will lose their tube, which does slightly reduce their fertility, but not by 50%. It reduces it so they still have about 80% fertility of what they had before. So it's not by 50%, but it obviously does reduce slightly. And then, of course, if they have another ectopic, then their choices become a bit more limited. So that's it. So I didn't do a case for hyperemesis because they all present the same, so it's really boring. But basically, I just all go through it because it's a very common presentation to A&E and to GP as well. So it's very useful to know, I think. And if you work in OBGYN, you're going to see it all the time. So hyperemesis. So it's just excessive vomiting in early pregnancy. What the patient will say is, I can't keep anything down. Can't even keep water down. But the important thing, again, is to check the urine. So if they have 2+ or less of ketones, then they don't need to be admitted for rehydration. If they have 3+, then we might need to admit them for hydration. So if you see a lady and her ketones are less than 2, you can give her an antiemetic TTO. So first line are things like cyclizine and prochlorperazine. Second line, metoclopramide and chlorpromazine. Generally, we avoid ondansetron in the first trimester, as there's a very small, really small, increased risk of cleft palate. So we tend to leave it till the last. If someone's really, really struggling, we talk about the risks with them, and we can give it to them if they really need it. But that's not for like an A&E, to be given. An A&E SHO is not going to decide to give that. If they are so sick that they can't take a tablet right now, you can give them a one-off IM injection, usually of Stemetil, and then the TTO. and that'll give them some relief so that they can then take an oral tablet, so then they can get on the right path towards feeling better. They don't have to come into the hospital. They don't need to stay in the hospital. The important thing with antiemetic TTOs is to give them 2, and to tell them to take 1 every 8 hours regardless, and then they have 1 as a breakthrough, if you like, to take in between. The important thing with hyperemesis is getting on top of the vomiting. Once they start vomiting, they can't keep the tablets down, and then they're never going to get anywhere apart from dehydrated. But if they can keep on top of it, that's the key thing. Women often think that that we will solve their nausea, which unfortunately they often will still feel very sick or still be sick, but it's just to make sure they can still eat something. So unfortunately, we're not going to completely cure everybody, but it's just to improve things, really. So if they do have 3+ of ketones, then fair enough. They can have a cannula and bloods. We need to check, obviously, because they're dehydrated, just check their UNE and LFTs. Again, as with anything, if they've not had a scan yet, then HCG. Give them some antiemetics, and then give them some fluids. So you can really be quite aggressive. They are young women, and they are very dehydrated. So you can give them a bag stat. I mean, obviously it's going to depend on the size of your cannula, how fast that's going to be, but ideally, it should be stat. And then second bag over an hour, third bag over 2 hours. So in the unit, we try and aim to have done the 3 units within 3 to 4 hours. 3 liters within 3 to 4 hours. Once they get to ketones less than 2 or 2, they can go home with the antiemetics, with 2 of them, as I said. If they are sick enough that they needed to be admitted or have rapid hydration, then we should really do a viability scan just to check it's not twins or something. If she's in A&E or wherever, you can try calling the EPAU of your local unit, and they can arrange that. So hyperemesis key points. Not everybody needs to be rehydrated and admitted. So not everybody needs to come from GP to come in. We'll get quite a lot of GP referrals like that. But if she doesn't have any ketones, she doesn't need to make the trek up to the hospital and just give her some anti-sickness tablets. Essentially, none of them are contraindicated in pregnancy. Only the ondansetron is the only one with a little issue, but they're safe in pregnancy. You can be very aggressive with IV fluids, and important to give a TTO antiemetics to break the cycle. Right, I realise I'm going over, so I'm going to be very quick with these ones. I am near the end, to be honest, in general. This is just a quick one. So again, this is another patient I've seen. She was 34. She was about 10 weeks from her LMP. She hadn't had a scan yet. She came with an episode of very heavy bleeding, but with minimal pain. However, the bleeding had now settled. She's otherwise well. Her observations were normal. So her abdomen was soft and tender. When I examined her, very small amount of old blood, but no active bleeding seen, and bimanual was unremarkable. These were the bloods that came back. Does anyone have any thoughts about those bloods? Anything interesting about them? Yeah, gesture is good. Yeah, I mean, it could be to be honest, with the history, it could be a complete miscarriage. Could be a missed miscarriage. Like Jess said, the thing that I'm getting at is that this HCG is very, very high. There's no real exact science, as I've said many times, about HCG. But if the HCG is in the hundreds of thousands, that is very high, and higher than we would expect in a normal pregnancy. So she had an ultrasound, and this is how it's described: a bulky uterus, heterogeneous mass with snowstorm appearance, no fetal parts. And this wasn't hers, obviously, but this is roughly what it looks like. So yeah, as some people suggested, it was a complete mole pregnancy. So gestational trophoblastic disease and molar pregnancy. Molar pregnancy is kind of like a subsect of gestational trophoblastic disease. I'll talk about it now anyway. So it's kind of a spectrum. So what you classically get is things like the complete or the partial molar pregnancies, and these are pre-malignant stages of this sort of spectrum of disease, if you like. It's like when you have, pre-malignant cells on your cervical smear, CIN or whatever. It's not cancer, but it has the potential, if left, to become cancer or to become invasive. That's why it's important. And then the malignant side of things, so the gestational trophoblastic neoplasia, are just basically the other end of that scale. So firstly, you get the invasive mole, and then this can turn into choriocarcinoma. And this can metastasize to different parts of the body as well if left. But again, it's very, very unusual in the UK to see metastatic choriocarcinoma. Very unusual. But there's the occasional one here and there. But it's not that uncommon to see the moles, because as you can see, they are rare, but at the same time, 1 in every 1,000 pregnancies. I mean, that's still a significant number, really. If you consider, most. I mean, I work at Wigan, which is a small unit, and we have about 2,000 to 3,000 births a year. So that's 3 small pregnancies a year, and more than that, really. But anyway, so bigger units, you're going to see a lot more than that. So I'm not going to go into detail with this because this is like a bit too much for me as well. But essentially, a normal pregnancy, you have an egg, you have a sperm, they come together and they make a baby there. If you have a complete mole, it's not very clear on this picture, but essentially the egg has no maternal genes inside it for some reason that we don't really understand. And but a sperm gets into an empty egg and is in there, but it just duplicates itself within the empty egg. So it's all paternal tissue, no maternal genes. And then in a partial molar, you have a normal egg, but 2 sperm fertilize exactly at the same time, pretty much. And then you basically get 3 sets of chromosomes, so triploid. And then you get 69 here, and then that is like a partial mole. So with a partial mole, sometimes there can be a baby as well, or a fetus, or the beginnings of a fetus. But mostly we normally catch them in the early, because everybody has a 12-week scan now in the UK. So it's very unusual to get much further than that, really. And generally, the fetus would normally not actually progress beyond a certain point anyway. But you may see on the scan that there might be like a fetal pole or something as well as the snowstorm as well. So how do we manage these? Basically, they should all have surgical evacuation because we need to get the histology to confirm the diagnosis. Especially with a partial mole, it can be quite difficult sometimes. It's not always clear. It can just look like a missed miscarriage. But if there's any suggestion that there's any molar changes, then they need to have a surgical evac so that we can send it to look under the microscope, basically, for formal diagnosis. And as well, if these women, they can bleed very, very heavily from this tissue as well, if they were to be left. If the histology does confirm a molar pregnancy, they have to be registered with a gestational trophoblastic disease centre. So in the UK, there's 3 of these. There's one in London, one in Sheffield, and one in Dundee. And those products will also be sent there for their special histopathologists to look at as well to confirm the diagnosis. So then the patient, after their surgical evac, and that will be done obviously locally, they were followed up by the Gestational Trophoblastic Disease Centre. So generally the local hospital doesn't have any more input apart from that they may take the blood, they may take the blood that then gets sent off to these units. Usually the patient doesn't have to ever go to these places. It's just that their blood or their urine gets sent there. They get, especially once they start doing urine tests, they just get sent the pots and then they have to post them, basically. That's how it is. They don't ever have to actually really go to these units. If they just have a molar pregnancy that resolves, they never have to actually go. So yeah, once the HCG is negative, then they just have they have monthly urine HCG sent to the centre for 6 months after the evac, or 6 months after it's gone down to negative. But however, why we need to monitor these women is that a small number of the complete molar will invade a little bit deeper, and if for these women where it invades a bit deeper, they may need chemotherapy to get rid of the molar tissue. It's an invasive kind of tissue. So about it's very broad, isn't it? 8 to 20% of complete molar, and only about 0.5% of partial molar might need to have chemo. Basically, there's several criteria for meeting. You really don't need to know this because I'd barely even need to know this. But it's basically just, if the levels don't drop as they should, or there's other criteria like they've got METs or anything like that, then they need to have chemotherapy. But it's a very good prognosis. So if you have a molar, that's absolutely brilliant prognosis. Most of them will be treated and not need to have chemotherapy, as you see. If they have had a molar, they should not get pregnant again for 6 months after they've had negative HCG, or for a year after they've had chemo. The vast majority, or almost everyone, will have a normal pregnancy after a molar pregnancy. There is a slight increased risk of recurrent molar, but it's not very high. Most women will just have a normal baby next time. If they did get to a point where they needed to have chemotherapy because of invasive disease, if it's low risk, GTN, you really don't need to know what low risk is, but essentially high risk are things like this distant metastases and things like that. So if there's low risk, then everyone gets cured in the UK. It's literally 100%. But if they're a bit more high risk, not everybody gets cured, but most people do. So this particular patient of mine, she had a surgical evac and she was referred to Charing Cross. Her HCG was negative within 6 weeks. She had her follow-up, it stayed negative, so it was all a good ending in the end. I don't know what happened to her after that because I left the hospital, so I'm not sure if she's had a baby since then, but probably. Hope so. This is real brief, just because in GP, you're going to see pregnant women in the early pregnancy, and they're going to ask you, can I continue my medication? And also in A&E, you're going to see women as well. So just a very quick list. I'm happy to send the list if anyone wants it. So definite no's are tetracyclines, fluoroquinolones, trimethoprim in the first trimester. Sodium valproate really should be a no, but occasionally women are on it these days, but it's very unusual these days. Obviously methotrexate, no. And they shouldn't be on ACE inhibitors, and we should avoid NSAIDs in pregnant women. But basically most medications are safe in pregnancy. That is the summary of this slide. All pain relief you can think of, apart from NSAIDs, is fine. All the antiemetics you can think of are fine, apart from ondansetron, less than 12 weeks. Almost all the antibiotics are fine. Pyritod's fine, omeprazole, Gaviscon, fine. These are the antihypertensives that we use. And pretty much all of the antidepressants are fine. And most of the antipsychotics too. It's with these women, it's very important, especially antipsychotic medications, to if they're stable on them, it is much better for them to stay on that medication and remain stable than to become unstable, even if there is a small risk of, fetal abnormalities or anything like that. Because the risk of them, having a relapse of their schizophrenia is much higher than the very small risk of problems with the medication. With anything, always just, if you have any doubt, I'm always happy to get a bleep to ask if a certain thing can be prescribed or not, or for advice about medications. That's absolutely fine. I don't mind to hear about that. And I don't think many people would have a problem with that. So just ring. Cocodamol is also fine. These days, if they're about to give birth, we give dihydrocodeine rather than cocodamol, but it's only because babies are a bit sleepy if they have codeine just before birth. But literally, I mean, like in labor, like before birth, you know. So if you're seeing them somewhere and they're in labor, then they're probably going to not be staying with you anyway for very long. But if they're not in labor, they can have codeine. It's fine. Yeah, a really useful place if you ever wonder about medication is the Bumps website. If you just type in Bumps and then the medication that you're thinking of, it will come up. It's a patient leaflet, but you know it's still useful for you as well. It tells you like how likely, what the medication is like in pregnancy and whether it's going to be taken in pregnancy. So that's always a good resource as well. The BNF's rubbish. It will just tell you never to give you anything, so don't bother with that. But Bumps website is good. That's it. I think I've been like answering most of the questions as we go along. So, but if anyone has any other questions, then I'm happy to answer. I'm sorry we overran a little bit. I did start a bit late as well. Sorry. We come back to this. I probably could have kept this up actually, not used my phone. I'll just give it a minute or so, see if anyone wants to ask anything. But no, it's fine. Bit of a whistle-stop tour, but that pretty much is all there is to early pregnancy, to be honest. It's not that complicated. Yeah, you do see these, they are everywhere, pregnant women. In what way more comfortable? I don't know. Do you mean like pain relief or? Brianna, sorry, yeah. Yeah, I'm happy to share the slides if people want them. I guess Divya can sort that out. I don't know.
Yeah, definitely.
Yeah.
We'll put up this recording on YouTube as well on Mind the Bleed.
Try and cut off the beginning bit where we didn't do anything for like 15 minutes. Which you probably can. Yeah, so pain relief, they can have pretty much anything, just not NSAIDs. So you can give them morphine, no problem. If they need morphine, they need morphine. We give morphine in labor, so you know they can have morphine. Or yeah, codeine, cocodamol, buscopan, anything like that. Paracetamol. Okay, well, if there isn't any more questions, then I guess that's it.
Thank you, Helen, and thank you, everyone. Have a good evening.
Thanks. Bye.
Bye.
Bye.